You heard it here first.
We finally made it. Welcome to RTBTH. Real talk beyond the headlines. It's about to get real.
RTBTH, 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 RTBTH. 5 letters, 5 words.
Spell it out.
5 letters, 5 words.
Spell it out.
5 letters, 5 words.
Spell it out.
Good talk beyond the headlines. Beyond the headlines.
All right. Back on the podcast. Hashtag RTBTH. Real talk beyond the headlines. We're continuing the conversation. The first part was Doc Talk Part 1. Check it out in the podcast feed. Now we're on to Doc Talk Part 2. I so want to name this podcast Fentanyl, and I will name it Fentanyl. But we're not only talking
just
about
being
fentanyl.
inflammatory.
You know, I mean, yeah, definitely trying to go for inflammatory, get some social media views and whatnot. But the conversation that we're having today is, I guess, in and around fentanyl. And we talked a lot about fentanyl on an earlier podcast. FAAX, Facts is the name of the podcast. Talking about the contamination of opiates with xylazine. And, you know, that's a whole other podcast. Literally, it's in our podcast feed. So listen to it. But so in Doc Talk Part 1, we talk about going through the doctoral journey. Both of us just graduated in the same exact semester, which is very cool. Despite the fact that you started later than me, and you know, I guess we've had different trajectories, and it was unclear like when people would be graduating, when not. So it's cool that we graduated at the same time, and we were just talking about, you know, the journey, what it was like, the hedonic treadmill and things like that. But over our conversation, you know, over the years and whatnot, it turns out Herschel and I have sort of had like an intersecting doctoral experience that I guess the nexus of it, or the tying factor is the fact that we've had like some kind of experience with the fentanyl crisis or the opiate crisis or the drug overdose crisis. So I'll say quickly, you know, my side, which is really just the past year, but I did my clinical internship at a federally qualified healthcare center in New Hampshire. And the agency that I worked at actually serviced a lot of people with opiate addiction. So they do a lot of prescribing for MAT, medication assisted treatment. So this is buprenorphine and, oh my gosh, what's the other one that
We actually don't call it that anymore, Tunde.
What's it called?
We don't use the acronym MAT. We use MOUD, Medicated Opioid Use Disorder Treatment.
You know, we actually don't even use that, Herschel. Did you know that we call it MM? Medication management.
Okay, what's that?
Medication management. Because it's no different from any other psychiatric medication. But all of this is semantic bullshit, because it's going to change. The name is going to change, or the acronyms are going to change in 2 to 3 years for whatever to be more.
Of course.
You know.
So you can republish. That's the only reason these acronyms change. So you can rewrite the fucking paper.
Well, go ahead and peep Doc Talk Part 1 if you want to hear about the academic publishing. That's his own treadmill in a way. The word I was thinking of is methadone. So medication assisted treatment, methadone, buprenorphine, and whatever. And I, you know, had a handful of clients who had addictions, and for different types of interventions and integrated care that I did, I actually had conversations with people who were high on fentanyl, who had used fentanyl earlier in the day. And it's crazy, like, people are saying fentanyl now, not even heroin. Like, people are like using fentanyl, knowing they're using fentanyl. A lot of people don't know they're using fentanyl, but like, you know, the hard drug of our youth was heroin. Now it's fentanyl, you know? So, but Herschel, what's your angle with the overdose crisis?
Right. So to start with, and you guys probably had heard it on some of our previous podcasts, I was working with the CDC and Division of Overdose Prevention. Previously, I have a new position now that's not working on that. But during 90% of my doctoral journey, that's what I was working on. So my dissertation is using those resources, that data, where we were observing emergency department visits involving overdose deaths nationally, and most recently, we're getting data from like commercial and public health laboratories that are getting like urine drug tests in for people. Let's say you go to the primary care physician and, they have an inkling, or, the provider, just has some reason to start drug testing you. They will submit a drug test to this lab. Same thing if you are already in a substance use disorder treatment program or a mental or behavioral health program. There are a bunch of different programs, addiction medicine, and even pain management, where you may be prescribed fentanyl for, whatever treatment or, cancer or something that's requiring such a high dosage of pain relief that, you are involved in this. And, one of the things that we were doing was comparing associations between not only fentanyl overdose or fentanyl use, misuse, and overdose, but how that's juxtaposed. You just mentioned the podcast we described with fentanyl and xylazine. Well, there's essentially this fourth wave of the opioid epidemic that's kind of been sparking up that doesn't involve just opioids anymore. It now involves opioids and stimulants. So we're seeing cocaine and methamphetamine mixed in, or people taking both, sometimes simultaneously, knowing and unknowingly. Sometimes it's, adulterated, one way or the other, depending on what the drug supply was. And then sometimes, somebody may have taken it and then, later they took something else. And it just so happens that, they were tested within the window of time where both those substances would present themselves, which still constitutes as co-use. You are, in the general drug detection window, which does vary, I'll say, depending on like your own metabolism, your body weight, your use habits, different things like that, your diet. But it's relatively 4 days. If you take cocaine and within, a day or two, you're taking fentanyl, both of those potentially can show up. I think 4 days may be the upper limit. So it's, if we're thinking about, less than, we had to put some kind of limit on that time frame, but it's been very interesting to observe that. So I'm interested today to hear more about your.
Well, let me just go ahead
experience.
Let me go ahead and jump into it. So,
Yeah.
I think this is a very interesting dynamic that we have, because I can give you like just one-on-one experience, whereas you're coming from it from a epidemiological public health angle, the sort of national statistics or statewide statistics. But I mean, I had, a number of clients, and over the course of my clinical internship, I would say maybe at any given moment, I had like 3 or 4 clients who had histories of addiction, or who were recently like sort of in a period of sobriety. So they had an addiction like 3-4 months prior to the start of our treatment or something like that. But on a few occasions, I would hear things like people are getting drug tested, so a lot of people are in programs with the criminal justice system where they have to do a lot of urine tests and whatnot. And people would say that like when they first initially started their treatment, they would be tested and they would have things coming up that they didn't anticipate or they didn't know they used. I think, one situation that I can recall is someone saying that they were testing positive for meth and they didn't intend on using meth. They didn't know they were using meth. I mean, I had clients who said that they were actively looking for both. I think also what you're saying is that a lot of it seems like it's just like that's what you can expect. That's like the standard, which is both together. The cut of the drugs that people are using is they're getting stimulants and opiates sold to them, and that's just what it is. It's kind of like the market is just turned into this like sludge of drugs, and it's just get high. That doesn't even matter how you do it at this point.
I mean, yeah, it kind of is that where, there are a lot of spaces, a lot of areas where, people's motive is to just get high. It doesn't matter what it is. And, they essentially are stumbling across, a new substance or a different substance, or, there are a lot of different reasons why, drug dealers or manufacturers or processors that are not, of course, coming from pharmaceutical environments, or, straight from the pharmacy, I would say, because I don't want it to be conflated with, people, pill mills and stuff like that. But, they combine these substances for different reasons. Sometimes it'll be for like weight for example, in the sense of xylazine, when they're like, they may have like a bunch of fentanyl or an opioid, and they're spraying it with this liquid xylazine that, may change the weight of the product so that they can essentially move more weight. But also drug dealers may change, their concoctions for effect. You know what? I'm always reminded of the movie American Gangster with Denzel Washington, where he had blue magic out on the streets, and all they did was, add a little color. I believe they made it a little blue or whatever, and, told people that it changed. I don't know. I don't remember if they actually changed like what the actual consistency or the product was, but a lot of it ends up being marketing, and they can, kind of describe all kinds of different things. Even in damn Breaking Bad, the one of the early seasons, I want to say almost the first season, before they even started like doing really good cooks or whatever of methamphetamine, which is what we're talking about, Jesse Pinkman was adding like chili powder or some shit in there just to be like, oh yeah, it's spicy. This, it's not changing shit. It's not adjusting your high. It might burn. It might hurt you more. It might, cause more negative effects to you, this person shooting up. But in terms of like the chemical composition, that chili powder is not actually doing anything but adulterating, quite literally adulterating what you are injecting into your body, which is an insane thing to, have somebody tell you, oh yeah, I put some chili powder in this, and then, here, you heat it up and shoot it into your arm real quick. Like, that's fucking crazy. But, on the mental side, there are a lot of people who don't think that that's crazy, that is, the lifestyle that they live. There are, hate to say it, but there are many high functioning stimulant users and abusers. And, to a lesser extent, I'd also say heroin and opioid abusers as well across this country, running, significant companies out here. I think we'd really be surprised if we were to, get the medical records for every last person. I think there would be a lot of surprises, but yeah, just to kind of
Herschel.
Background.
So
E-ball, yeah.
So we talked about this in the Facts podcast, but can you kind of like, maybe give us a little bit of epidemiological story about like what the crisis is? I can kind of, tell you a little bit about New Hampshire just because I did some research, but like I guess I was kind of experiencing this. I didn't realize, like, I guess I knew that New England, even Massachusetts, where I live, has had like a lot of has had like a problem. Like, it's been like a sort of hot area for these overdoses. But apparently New Hampshire was number one in the state from 2014 to 2016 in terms of overdose deaths.
In the nation?
Did I say
number one in the nation?
Yeah, number one in the nation. The state of New Hampshire, number one in the nation in terms of overdose deaths per capita. And then that was 2014, 2016. And then they were top three later part of the decade. So I don't know what it's like in the 2020s, but I'm just saying, like, myself, working at that healthcare agency, and even the surrounding areas, you see a lot of people looking like dementors, Harry Potter.
Oh yeah,
there, looking like ghouls,
straight zombies.
Yeah.
Yeah.
And so I guess New Hampshire is a hot area. Perhaps maybe you have more specific statistics, but
yes.
I guess what I'm trying to say is just like, this problem is very bad in places that it's affected by, like in nice neighborhoods, in large cities where there's still a lot of addiction, but people, there's so much other stuff going on that it's not necessarily in your face, and people come to large cities to get treatment. So there's probably a lot of people who are healing, getting care in large cities like Boston or Atlanta or Houston or whatever. But in these rural areas, man, it's like ravaging, communities and people, and I just recall people who would come into the clinic and they just, like, for years and years and years are like fighting addiction, like using and not using and being addicted and trying to take care of their family and themselves and trying to have a job, but they're using and they're addicted. And it's just like this virus, man. It's like an infection of addiction.
It is. Okay, so that's a lot of stuff, but I will definitely try to cover as many of those points as I can. First off, so I'm going to start with, overdose deaths and incidents of non-fatal overdose have been on the rise for literally like the past 30 years, however old we are. Like a lot of this has happened during our lifetime where it took off. And just for perspective, some of these pharmaceutical drugs have been created in like the 60s and 70s. Fentanyl is not a new substance. It only most recently started to get used in the medical sense, and beyond the medical sense to be abused. But there are many, many reasons why like it affects rural and urban communities very differently. And similarly, but like obviously one of the things that kind of happens is like it's more in your face in an urban environment where, you know, human beings are literally and figuratively living on top of each other. Where, you know, you're going to see homelessness in the streets, where, you know, as in a rural area, it's going to be much more spread out. You know, they may be in the backwoods somewhere, you know, cooking up and doing whatever it is they need to do. And a lot of people end up having out of sight, out of mind kind of mentalities about it. But in terms of the rural effects kind of just continuing to spread, one of the factors, of course, is access to care. There are, I mean, shit, in Georgia, not in the rural area, in Atlanta, Georgia, this hospital's closing all the time. Surprisingly, all the fucking time. We've closed, I don't know, like 3 or 4 under Governor Brian Kemp, which is fucking wild. They're moving Eggleston Children's Hospital at the end of this month. They're moving it out of, so it's literally right next to Emory. Right now, it's right next to Emory Hospital. We've had to take our son over there, actually, when he was first born for, you know, a little minor thing. He's fine. He's fine, everybody. But the hospital is moving much farther away from us than we would really like. It's and that was a factor in, you know, when we first were even buying our home, like, all right, you know, we don't want to necessarily buy way over here because there's not really access to any, you know, hospitals for us as adults or children's hospitals. And that's just a thing that kind of has gone on and on. But to give some like true background on like how things have changed across the last 30 years. So we're about 34 years old, you know, out here.
Real quick.
Living our lives.
Yeah. Sorry to cut you off, but real quick, there's been this ongoing saga of this healthcare organization called Steward Health that runs like a lot of hospitals, and they have a handful in Massachusetts, and they, I think, are filing for bankruptcy, and there's a lot of influence from private equity. But, you know, it's been like this sort of ongoing saga within the Boston and Massachusetts news cycle where a lot of hospitals are closing. I don't know what the cause is in Georgia, but, you know, a lot of people are saying like a lot of financial skullduggery, you know, executives taking large paychecks and, you know, cutting a lot of corners, and, you know, the agency basically becomes insolvent because of extraction of financial resources, you know, which is kind of the reputation that private equity gets. But yeah, it's a problem. Hospitals closing, I guess, nationwide, based on what you're saying. But sorry to cut you off.
Yeah, no, that's a great addition. I'm not well versed on the actual reasons here, but I imagine it's something similar. I mean, you know, we can talk all day, have another fucking podcast about the American healthcare system. There are many people talking about that shit right now. What's this dude? Cam James on YouTube just had a podcast a couple of weeks or a month or so ago that was discussing some of the elements of it. And I think it is one of those things where, you know, economically, it is not sustainable, you know, for extended periods of time. And one of the big things, okay, so this is a thing that's, I know was at least relevant for Georgia and likely very relevant for many, many hospitals. I talked to a few that, you know, were jurisdictions that I worked with, but essentially during COVID, because we were having a fucking global pandemic and a lot of people were taking up beds, and like a lot of either voluntary or necessary medical procedures, which cost money, the hospital charges big money to these insurance companies they could not, you know, execute a lot of these procedures, or they just kind of got kicked down the road or whatever. That was a lot of money out of the pockets of these. I mean, you know, I shouldn't say pockets because, you know, there were private and public hospitals that were closing, but it was a lot of money that was lost out on. And it is economic. It is money reasons is the only reason that a hospital would close. Now, I will say, speaking of money reasons, the new hospital for that children's hospital in Atlanta, because they're moving it to, I think, actually kind of near the CDC campus, near it's not Century Center, but it's over there. It's like maybe Emory Executive Park, I want to say, off 85, kind of near where you used to live, Tunde.
Yeah.
Not to dox you, but, you know, 8 years ago or whatever the fuck.
Yeah.
But basically,
Arthur Blank Hospital.
Arthur Blank Hospital. Bro, you Googled this shit and
God.
found it before I could even say that shit. Yeah, this shit's crazy. So,
Arthur Blank is a good dude, though. I think, right? He's a good guy.
Yeah. I was gonna say he is doing something that like it does literally support the community. It's moving further away from us, which kind of sucks. You know, it's moving up North Druid Hills, so it just happens to be away from us. But like, if they were to have closed and not reopened another children's hospital, that would be much worse for the community. I mean, it just is another systemic thing because, you know, what you'll notice is the hospital moved north. I'll say that. It moved north to where there are more funds, there are more resources already in the city of Atlanta, which, you know, is a trend that has continued to happen and is represented across many, many cities all over the place. But anyway, because we're not talking about that right now, so I'm going to give a quick background on like, you know, what's been going on with the overdose crisis in the past 30 years, just really quickly. So there's basically been, initially there were 3 waves that have been described. You know, the first wave being like the late 90s, there were prescription opioids that were just kind of running rampant. They were overprescribing. You may have seen some of the documentaries like, or docufiction series like Dope Sick was one that was on Hulu. There was another one that I'm not remembering right now. It goes into like how the Saglers and Purdue Pharma basically kind of flooded these doctors and the streets with prescription, you know, medication and stuff like that. And then basically people realized like, oh, this is actually kind of bad. We're creating a zombie apocalypse for real. So there was, you know, as expected, a government, you know, mandated, you know, and I know people don't like mandates or whatever, but like people need to understand what the fuck a mandate means. It is not required, recommended. Like if you don't want to adhere to the mandate, you can go somewhere else. People just don't understand that, you know, when people say, oh, these vaccines are mandated. Okay, it's a mandated vaccine. You can't get in this building without a vaccine. All right, well, you need to go to another building, which is totally fine. People shouldn't care, whatever. It is for your well-being and benefit, generally speaking, but, you know, you need to kind of know and understand. And so throughout this process, I even, you know, read a lot of reports and stuff. I was on a committee where like each time there are new guidelines, you know, we changed the word in most recent years from mandate to guidelines in terms of like prescribing rates. And basically, you know, people who are already receiving these prescriptions for long periods of time, they're like, oh man, you know, I need my pain medication. Like they're in pain. So they're advocating for themselves. They're writing, you know, strong, long, hateful letters of like, you don't care about this and da 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 da. It's doctors and like people, not even just the people who are directly affected who are writing their own letters, but the doctors are like, oh man, you know, my patients can't get whatever they need. Da, da, da. Like, and so you kind of have to take that into account of like, okay, this truly is affecting people's lives for sure. But in the interest of public health, in the interest of literal public health, it's best to have these guidelines to where like you can't just prescribe everybody everything. You need to have PDMP, which is prescription drug monitoring programs in place so that we can know and understand, all right, you didn't just get drugs from this hospital or this doctor's office and went down the street and got the same drugs so that you can continue to pop them or sell them into the community. You know, those are all things that were and are essentially happening. But basically, you know, that was late 90s, right? So after, you know, they kind of cracked down on, you know, those prescription drug policies, heroin overdoses blew up. You know, heroin was kind of happening previously in, you know, the 70s or 80s and stuff like that, but it wasn't in the communities that these people really cared about. And you guys know which communities I'm talking about. So now this started happening like the 2010s and onward. And I even remember I had a knee surgery in college, December 2009, and they gave me hydrocodone. And my parents for sure took most of the, like I, you know, after the surgery, I took some and it gave me headaches. It made me sick. I was like, oh, this is not, I don't like this feeling. Actually, it makes my hand shake.
Man, I've encountered the opiates and I always get sick. You know, if I have to go to the dentist or, you know, whatever, if I need to be prescribed painkillers, I always tell them, just give me like the strong ibuprofen because I can't, you know, that shit makes me sick. But yeah, anyway, go on. Yeah.
So, and there tend to be two different camps of people. Some people hit a euphoria, truly, and it can be very toxic. So essentially, this is 2010s. Heroin overdoses are going up. So, all right, well, we have a new target to kind of identify. And there are things, you know, social programs, different things you can put in place. There's drug supply that, you know, becomes an issue. And, you know, I don't want to hear nothing about, you know, Donald Trump and the immigrants bringing shit in. That's not how the shit works. It's coming through natural ports. People not swimming across the Rio Grande and then huffing that shit on backpacks across. It's coming through where you would most expect that shit to come through, not where you'd least expect it to. So, you know, that's the 2010s kind of going on. And then like 2013 onward, synthetic opioids started to really take off. That's where you're in your fentanyls, truly, which are that much stronger. I want to say they're like 50 times stronger than heroin per dosage. Morphine dosage is like the standard. They use morphine as the standard measurement.
The single unit
pain relief or what? Yeah, single unit or whatever.
Mm-hmm. Yeah.
So fentanyl starts to pop off, right? That's about 10 years ago from now. So really not that long ago.
Mm-hmm. Yeah.
We were still young kids out here running around, making mistakes, doing all kind of nonsense.
Doing a little fentanyl here and there.
And people didn't have a hold on it. Please. But that's the thing. If you were doing some shit, it's possible that the shit could have been out there. But, and even beyond fentanyl, so obviously fentanyl is the culprit, but like there are analogs that are produced. Carfentanil is one that's, N times stronger than fentanyl. Parafluorofentanyl is another. Like there are many. I can't even
let
name all of them.
Yeah, let me jump in for a second, because everything that you're saying, you're talking about it from a statistical angle, or I guess epidemiological population statistics and whatnot. And so real quick, the other documentary is Painkiller, the one that was like a little bit more focused on the Sacklers, and Dopesick, not a documentary. It was a drama series. Both Dopesick and Painkiller are really good. But I want to make a suggestion as well. A book called Empire of Pain, which is like a huge book. I did the audiobook, but Empire of Pain covers it's actually a really in-depth psychoanalysis of the Sackler family. And that it was such an enlightening book about the Sacklers. Like, here's a super random fact, but that movie OG with the guy, hold on, who's an excellent actor, and I'm forgetting his name right now.
And links will be in the description.
Jeffrey Wright.
To find that book.
Yeah,
okay.
Jeffrey Wright.
Nice.
He was the main character in the movie OG. Pretty good movie. It's straight to HBO movie, whatever. But the director, I think, is a Sackler. Yeah, Madeline Sackler. So it's just like one of those things where like it's whatever, but until you know what the Sackler family has done and what they've been involved in, it's like striking, like. So as I said, it's like a very in-depth psychoanalysis of the Sackler family, but it also traces those waves that you talked about in some good detail. And one of the things, that ties the Sacklers into what you were talking about is that the Purdue Pharma, they invented OxyContin, which was like a slow release opiate. I don't remember. I think it might have been like some analog of morphine or something, but pretty strong opiate. And there's all this science hullabaloo, which is not science, basically, where it's not addictive and whatnot, and they get the sales agents to push it on to the doctors and whatnot. But it's just like this it's like a tinderbox for a crisis, because people are sort of adapting slowly to this drug because of the slow release, but they're getting like a heavy dose. So they're not getting like necessarily the sort of like, impactful, like, hit of a dose. But they're getting a lot, but then eventually they become addicted. And interestingly, you probably know this, but Purdue Pharma actually got charged by, I think, the federal government or one of these agencies.
They did.
And they got convicted in like, oh, wait.
100 mil? Was it 100 mil?
I think it might have been like 600 million.
Whatever it was.
Yeah. That first one was like 600 million. The second one is still being litigated. And there's been a lot of shit with that as well. But then they eventually reformulated OxyContin so that so with the original OxyContin, people could break it open, and I guess they could like treat it like a drug, like a street drug, and get like a hit, but with the reformulation, they turned it into like this like gum, like a gummy kind of thing. It was like you couldn't break it open. Like if you try to break it open, it would just like sort of like a Skittle would like kind of break like a Skittle would and just like turn mushy or whatever. So that actually kind of coincides with the uptick in heroin, which you said was like 2010. Because they got convicted in 2008, I think. So it's like, OxyContin. A lot of people do place all of the blame on Purdue Pharma and the Sacklers. I don't think it's just them. It's a confluence of things, but you know, they have a massive stake in this crisis. But it's like that change, that shift, and then the prescribing practices, the prescribing mandates, or the prescribing, you know, culture that was changed. Now people have become addicted to things like OxyContin, these very powerful drugs, but they need to get their fix after they've become addicted, but they can't get their hands on the drug, or the new formulation of the OxyContin is not the same thing. So then they have to turn to something else, heroin. And then next thing you have drug cartels, and I guess China is sending the chemicals to the drug cartels, whatever, and with the fentanyl. And then, you know, they're just advancing their business, making their business more lucrative. Fentanyl is a natural next step. And next thing you know, we have a fentanyl crisis. So it's just like, shit's just kind of like evolving into hell.
Yeah, it's pretty interesting that, you know, many elements of society turn into this Cold War, basically, where like, all right, well, one side does this, and then, you know, the other side retaliates by doing this or making some change, or, you know, adding some kind of litigation here or legislation, I mean, here or there. And I mean, it's always funny to me because I also, you know, recognize it happening in like the streaming wars with, you know, cable companies and people pirating shit and, you know, trying to get around sharing passwords and different shit like that. Like there's always going to be something new to kind of, you know, battle against, which is why the war on drugs does not work, because it was always a guerrilla war against, you know, a not real target. You know, when you say the Mexican cartel, who the fuck is that for real? Like, because they caught El Chapo and that shit didn't stop, and his ass escaped like twice.
Mm-hmm.
They caught fucking, I mean, you know, I was going to make reference to like Tony Montana and Pablo Escobar and stuff like that of old, which was cocaine, not necessarily some of what we're describing today. But like, there is no real like, you know, state that you can put this on. This is not a true war. So again, you know, the Reagans and, you know, Nancy Reagan or whoever the fuck talking about war on drugs, that set us back, you know, from the 80s or 70s or whenever the fuck they were doing it.
Nixon.
And even now, you know, we're trying to recover. Okay, Nixon, yeah. So we're even now trying to recover from, you know, those precedents there where, again, you know, off mic, before we started recording this, we were talking about octogenarians and shit like that in government. But like, again, you know, shit has changed, and it's changing too fast for them to kind of recognize and understand that this is not the battle that you want it to be. Net neutrality was another thing of just like, bro, how do you can't keep up with, you know, how the internet and social media and all kind of different shit is changing, and you trying and you being 100 years old, you're never going to be able to kind of, you know, acknowledge and understand it, which is why, you know, they need to appoint your boy as the head of the, damn, what's the name of that division? I have
the DEA
somewhere. I mean, maybe, but no, just like whatever council the drug overdose reduction, like the president, the White House has
the task force
team.
Is it a task force?
Yeah, for sure, it is. It's a task force. Yeah, and your boy, I've been on a couple of task force for like opioid overdose and stuff like that, but not the White House one. You know, they're up there again, you know, sending policy down, you know, setting the agenda of like, all right, we need to look into this and da da da. But basically, speaking of, you know, the government kind of describing, you know, how some of this shit is going. And, you know, so that's basically kind of what all has happened up to like 2013. Yeah. And then after that, you know, we're talking about now 2015 up to through 2022 or so. Like there's new data, of course, coming out through now. But that's where we're seeing more stimulants and things, psychostimulants, which is a word that we're also trying to get away from. But that really just means amphetamine or so a lot of the language is charged. That's the thing. You know, we know words are very important. Stimulants cover it. And some researchers do use the word psychostimulants, just like some researchers use the word MAT or MAT for medication-assisted treatment. But like, you know, we try not to even use often the word abuse or different things that can be stigmatizing.
You
know, especially because a lot of this we're also working with, you know, the goal is to work with, you know, stakeholders who like are actually involved in the environment and, you know, are maybe recovering and have insights into how like we can actually present these different.
What's wrong with psychostimulants though? Like,
I mean, I'm not positive. I didn't make the decision. I know I wrote it, and my advisor was like, "Actually, yeah, we can't. We're not gonna say that. We're gonna just say stimulant. It just means something different." I'm pretty sure because the word stimulant being more broad is just better. And even my analysis was cocaine and cocaine analogs, which there are some, and methamphetamine. We didn't go into prescribed stimulants, including Adderall, Caffeine.
That's
is a
what they're
stimulant.
called, psychostimulant. Like the prescribed stimulants. Like we refer to them, mental health practitioners as psychostimulant. But
methamphetamine though is one. Methamphetamine is a psychostimulant, is it not?
Well, in terms of
and it is categorized. Well, I mean, because that's the thing. Adderall is it not an amphetamine?
Yeah, it basically. I mean, I don't know the psychopharmacology or the pharmacology, like the chemical structure and stuff, but my understanding is
pharmacologist on the pod.
Yeah, indeed. But I know that it's like very closely related. I mean, a lot of people would just call it meth, like prescribed meth. So I don't know to what extent, like what the sort of chemical molecules, whatever, that make it this or that. But yeah. Real quick, so it was the settlement for Purdue Pharma was in 2007. And it was a settlement, not a conviction, but still a lot of tomfoolery, skullduggery, as I said. And about the language thing, I agree with the language thing. I think there is ways people can be word Nazis, and I feel like.
I mean, I agree. I understand. But
Yeah.
So the point that the place I was coming from is like, as I'm publishing under potentially a government entity.
Yeah,
that's part of why like there's a clearance process. Like, all right, you can't use some of these words, and I totally understand that they weren't changing the message of what it is I was saying, so I'm fine with that. And again, speaking of words, we might have to name the podcast "Fentanyl Skullduggery."
Hell yeah! They're all perfect. Yes. But no, I think that language is very important and powerful. Like I try not to say substance abuse. I call it substance misuse or heavy use, like heavy alcohol use. But the primary. Oh, were you talking about SAMHSA, Substance Abuse and Mental Health Services Administration?
Well, I mean, so that is one.
Yeah,
well, it's not abuse. Is it abuse?
It is. Well, see, that's the thing. Is like you need to get your shit together. Like the agency, the number one agency. I think they may even be the forefront agency for mental health in general. But most definitely substance abuse, and they do this survey every year. They fund it, and I guess they probably have people who research it, but I think they outsource the research as well. But they publish a survey called the National Survey of Drug Use and Health every year. NSDA or NASDA, I think.
NSDA,
NSDA. Yeah. Pretty. It's like a very, very. Anyone who's out there, talking doc talk. Anyone who's out there who's going to do a dissertation, look, get NSDA.
Yeah, for sure. Yeah, one of my first projects was on that.
Or in general, I got to do a quick tangent. I should have said this on Doc Talk Part 1, but look, do not waste your time collecting data for your dissertation.
Please, yes, 100%. Oh my God.
I know. I think in some circles, people think that it's not a real dissertation unless you're collecting data. You have like a theoretical process. Look, I was told this like probably the second month of my doctoral journey. The best kind of dissertation is a done dissertation. And look, find you a data set. There are a million research questions that you can answer, and just go ahead and handle that. That's what I did with the UK Biobank. You did that as well. I don't know what data set you used though, but
I didn't use a bank. So it was collected data. It was secondhand data from a commercial laboratory and other CDC resources that we had, which were like death certificates and then non-fatal overdoses from like emergency departments. These are, I don't think they're publicly accessible. I think you might be able to request it and get access through the state level. Like I have it nationally and can write and speak to it nationally, but I'm pretty sure you can't just get it everywhere. But a lot of the stuff we do is either, correlated with NSDA or HCUP, which is hospital, hospital something. It has to do with like how it's insurance billing and stuff like that. But we have a bunch of them. We have a ton of different data sources that we use. But salute to that. Don't collect your own fucking data. I mean, if you can't get it from the census or the ACA, which is the not ACA, ACS, which is American Survey something. No, it's not
census survey. Something. Yeah,
American Community Survey.
Gotcha. Yeah,
rewrite your shit because you don't need to be out here collecting data. My initial advisor tried to get me on that, and I was like, it's only 50 subjects that you need to just
like a survey.
I was like, fuck out of here. Yeah, and it was in person. It was on COVID shit.
God.
I was like, absolutely not.
Well, I mean, look, I'll say this. Like,
I mean, you could, and it's useful. Somebody has to do it. Somebody does have to do it.
No.
So I recognize that it's important.
Let a
but,
government
they pay
agency
those
do
census
that.
motherfuckers to get out here and do that shit. They don't pay you, the doctoral student, to get out here and do that shit. They don't pay you enough to do it at the very least, so don't do it. That's what I would say.
Well, I agree. And look, that's where I stand. Get you a secondhand data set. But I will say for psychology students, I can understand if they want to do like qualitative interviews, and have like people who do more humanities type research or even social science, and, people may like be embedded in a culture in a different country, a community in a different country, and they're doing like interviews or collecting like, I guess they're called ethnographies and other different types of research methods. I can understand some people want to do like interviews and sort of do like thematic analysis, but I'm like, look, it depends on how much pain you want to go through. And if that pain is not pain for you, for me, it's pain. I'm sorry. Give me the data set. Let me be on my way. But, I guess I'll hop down from my high horse and say, preferably you should get a secondhand data set. But I understand if you want to collect your own data and have some magical research question, which is not going to be true because there's plenty of research to show that most research studies, John Ioannidis, sorry, I have to go on another tangent. John Ioannidis, a professor at Stanford, published this paper in like 2005. And it's like one of the most cited papers of all times. And this study is like most, hold on, let me look it up real quick. Most research is false. Why most research is false? Why most published research findings are false? Because of all of the different things that go into doing research, between the collecting of data, the research questions, there's so many possibilities for confounding variables to influence the actual result, so it's probably not true. Whatever research publishes in any independent study is probably not true, but obviously science is done with a compilation or a collection of studies. Yeah. So anyway,
exactly.
Sorry,
Absolutely.
let me get off my high horse.
Nah, that was great. That was great. Tangent within a tangentception out here. That was good. But so just to wrap up, like the point that I was making about the fourth wave, which is like 2015 onward, basically, where we're seeing the psychostimulants and the stimulants or whatever, and fentanyl out here. And just for terminology's sake, when people say something like, "Oh man, a speedball" or something like that, that's cocaine and heroin. That's a mixture of those two, and that's an old term. Like they have new terms for the new shit, but talk to your local drug dealer about that. I'm not going to give you that information, but like it is not uncommon that people are, mixing these things. They're, getting essentially a depressant and an upper, and they're, riding that high. It's very, very bad for your heart though. Your insides, your fucking homeostasis in your body is incredibly conflicted, but that's to each their own. But so, we were speaking on, the government entities and how they're, kind of treating and addressing this. And so I do have essentially, it's not a quote, but this is from the U.S. Congressional Budget Office, and their description, it's from a report from the U.S. Congressional Budget Office on the opioid crisis, where they essentially acknowledge that alongside socioeconomic factors and changes in the illegal drug or in the illegal opioid market, demand for opioids increases among the people who experience declining real wages and social circumstances. Oftentimes those are people obviously in poverty or people in rural areas where, they're not seeing new jobs or raises or, new factories or businesses or whatever are not moving to their community. And those social circumstances include worsening mental health care or mental health, more social isolation, like, for example, something that might happen in a pandemic or if you were in a rural area, and reduced access to care, where, again, we've been talking about closure of facilities, and it's not even just hospitals, but it'll be these treatment facilities as well that are very important to kind of sprinkle around. And even now with my new team, I'm looking at an analysis where we're looking at like access to care. It's through the American Hospital Association, where we're looking at different chronic diseases. So this doesn't have to do with drug overdose, but like access to care is a very huge thing. When you shut a hospital down near some people or a treatment center near somebody, it will throw a lot of shit off. Because if you have to drive even 30 more minutes to go get some care, or, oh man, I have a little cold, or I'm sick, or, I'm feeling a little under the weather, and you add on, a few more miles, for sure, people are going to be like, actually, no, I might stay home. Maybe I'm just going to eat a little worse, and, this diabetes isn't too bad to live with. I'm going to just, keep on pushing until it's too late. kicking that can again down the road, similar to how we were describing kicking this, overdose can down the road for the past 30 plus years. We run into much more adverse outcomes way down the line.
Absolutely. Well, I think this is a good segue into one of the topics that we listed, which is the solution to the overdose problem. Hint, there is no problem, but it's very interesting.
No, there is no solution.
My bad.
There is a problem.
Well, I don't know. I mean,
whoa, Tunde, whoa, no, there is no problem. Whoa.
I mean,
sorry, I had to cut you off.
Have you ever tried fentanyl? I mean, it's not really a problem. No, I'm kidding. Just kidding here. Just kidding. But no, there is no solution. And, it's very interesting that you brought up what you just did, because in the little research that I did to prepare for this podcast, I read an article entitled Opioid Crisis, no easy fix to its social and economic determinants. And the article is basically just arguing that we've gone about this in a way where we have this very, I guess you could say, blunt force method where we want to decrease opioid prescribing, or we want to have a war on drugs, or, even some of the harm reduction methods is like, we want to make sure that people can safely do drugs, but we're not addressing like this sort of more longitudinal problem, a lot of it having to do with social and economic determinants. So in that article, or in another article, actually, one of the sort of strongest, or a handful of the strongest predictors people having long-term severe opioid addictions is, one of them is early experimentation. And then things that you mentioned, legitimate opioid prescriptions. So people who had legitimate opioid prescriptions prior to having severe addictions, and then self-medication of mental health symptoms and intrafamilial substance use. And, there are other factors as well, but I want to touch on namely early experimentation, because this is something that like really, really was striking for me in my clinical internship. A lot of, obviously as a therapist, like you're asking people about their lives and stuff, but a lot of the work, at least to start off, is really just interviewing people about their history. And I heard this over and over and over and over again, but people were exposed at very young ages to many different substances. And I found that it started off with like alcohol and cannabis and, another tangent, but there's like a lot of conversation.
Gateway drugs.
Yeah. Conversation about them being.
We don't condone that terminology as well for alcohol. Kids should not do those.
Yeah.
But
yeah.
Describing those as gateway drugs is not accurate. That's all.
I agree, but in my view, it's like an on-ramp at an early age, and it's because like you have no exposure, so you just go for what's most easily readily available. The gateway concept is the gateway concept, the perverted version of it is that you use something and it's like automatically you're going to start using harder stuff. It's just like a sort of funnel. You're automatically funneled into using harder stuff, which is not the case. But at young ages, I think anything can be a quote unquote gateway drug. But I had clients who were telling me that they were exposed at like age 10, 12, 13. And I had clients who were in their 50s and, a handful who were in their 60s who had only recently started becoming sober, so we're talking about decades of addiction. And I'm like, of course you had no chance. You were using opiates. Like I had some clients who were addicted to opiates by the age of 18. I'm like, how can you possibly escape that? Imagine being addicted to heroin before you even finish high school. Like, think less of really actually taking on like real life responsibilities, having a job or starting a family or whatever, paying taxes, But I just found that very extraordinary. Like we have this, like I said earlier, these blunt force methods, like just prescribe less, or something. Even mental health is just like, just make sure there's more mental health services available. Like we got to set up more clinics. People have to get more access. We have to prescribe people more psychotropic medication. And I'm like, or maybe we could just try to make sure no child is exposed to drugs, obviously this has a lot to do with like the family and whether the family is putting children in bad situations. And of course, if someone is addicted, they are not going to be providing the best care for their child, and their child may have exposure to hard drugs. But
damn, it's crazy that the cops are coming for you for saying all this.
Oh
stuff
my
too.
gosh.
That's wild that they're pulling up at your door, right? Hey, stop podcasting in there. Stop sharing with the world.
right,
The right answers.
stop telling the truth.
Continue.
Cops-
Sorry, listeners. Sorry. No, it's
Cops always trying to pull up when I'm doing. I think the last time that it was like very evident was when we did facts. So maybe they do. The cops really are out here hating, trying
got
to
5 stars out here today.
trying to treat me like Tyreek Hill at them. But yeah, like the early exposure to me was striking, man. Random story. Okay, another slight tangent, but getting a haircut at the barber, this is probably like 9 months ago or something. And I was telling the barber about like kind of the work that I do, and it was so crazy because the barbershop that I got that haircut at was the last time in that specific barbershop. I still go to the same barber, but the reason why the barbershop was shutting down was because the owner of the barbershop, nothing to do with the barber knows him, but my barber had nothing to do with this, got busted for selling drugs. And apparently he was pushing weight, so we started talking about drugs, and I said what I told her. I was like, one thing I've been learning is that people get exposed early. I'm talking about hard drugs. It might start off with like, let me just steal some alcohol from mom and dad's cabinet or something, but like it just escalates, and people dabble with mushrooms and psychedelics, and it's crazy because psychedelics are known and thought to not have addictive potential, where in the sense that people don't go back to it impulsively or compulsively. But in children, I think it might be different. I think children may have more of a compulsion to use it. So people will kind of have like, in my experience as a clinician, people have a phase of like psychedelics in like their teenage years, and then by the time they're 20 years old, they're using stimulants and heroin and opiates and whatnot. But he was saying how, and I think this is kind of like, this is a testament to the complex psychosocial factors and economic factors. But he was saying how when his son was very young, like I guess close to a baby, he said that, his son was kind of crying and, being a little fussy, and he said he just gave his son like a little bit of alcohol, and he was just like, I don't know why I did it, I just, and he's like telling me like, it was like the stupidest thing I ever did because now his son is an alcoholic, and it's just like, what the fuck? First of all, I'm thinking, what the fuck were you thinking? But, black man, inner city in Boston, I don't know what his life is like, but, he probably has some struggles, maybe had a child at a time when he wasn't prepared to be a father and whatnot. And, but it's just like those small moments, very short moments of just like, oh, here's a little, and I mean, the kid was a baby, so maybe the kid didn't have any sense of what alcohol is that would have impacted a long-term alcohol addiction. But that's the exposure, and I hate to kind of put it on parents, and it's like the parents need to keep their kids away from substances. Like, it's that simple, even, yourself as a father and other young fathers, who just recently had children. Like, I'm sure the relationship with smoking weed is a whole lot different. It's just not just like roll up and, start puffing, blowing it down, because weed is a more innocuous, I guess it's not as dangerous, I guess you could say, as other drugs. So, we kind of treat it very nonchalantly, like rolling up, smoking, go to the concert. I'm sure that shit goes out the window if you're a responsible parent. But yeah, anyway, sort of did a lot of talking around your original point, but your original point being the socioeconomic, the psychosocial factors are the real fight, and it has been very erroneous for us to treat these things like wars on drugs or wars on doctors and prescribing and whatnot, when we actually have a crisis of meaning and purpose and economic stability. And one of the angles, forgive me for going in lecture mode. I am a doctor, so I think I have to. Like, I think it's in the contract.
Tone?
Yeah, forgive me for professing, but I think I have to. I think it's in the contract when you get a doctor, you have to profess. But anyway, A lot of the conversation from the psychosocial angle is in the context of what's called deaths of despair, but people dying from addiction or suicide, or, you know, these sort of chronic long-term illnesses that can be treated effectively if people have access to healthcare. So that's what we're dealing with, you know?
No, I definitely feel you. And yeah, it's even, you know, knowing and understanding what some of, because I'm not saying that all of these things that we're describing are the whole quote unquote solutions to this problem. I don't know how you address them because there are so many and they're so kind of like spread. It's almost a shotgun blast of like, okay, well, you know, what do we invest in first to kind of, you know, shore up, you know, this element of, you know, lack of mental health resources or, you know, helping to reduce, you know, the feelings of social isolation or wage stagnation. You know, what thing do we focus on? Because if we try to focus on all of them at once, it's the same thing that always, you know, has continued to happen where like it looks like nothing. It looks like no progress at all.
Yeah.
And for those who are putting the money forward, essentially the taxpayer, you know, and when we're describing this as it's the government's responsibility to kind of take care of this, they're going to want to see, you know, progress and results. And it makes it difficult to convince Congress people, you know, following that to continue to pour money into, you know, these programs and, you know, research and different stuff like that. So it's really, really, really terrifying to just kind of, you know, sit here and be like, oh man, yeah, we know what the problem is. We know what some of the things that, you know, could be solutions are because, you know, let's say, for example, compare ourselves to other developed nations that don't have this problem. And there's some other problems that this nation has that other developed nations don't have that we won't touch on today. We could, but we won't.
Mm-hmm.
First off, there are other, you know, I do want to address, there are other Western nations, developed nations that have drug problems. Canada has a very similar one to the United States. And now we all know what that is, how that is, because Canada is in close proximity. And, you know, it just is they have a similar cultural makeup as we do. You know, a lot of the border cities where, you know, you're seeing shit go down or there are ports and different things like that. You're seeing the same, you know, influx of drugs and, you know, subsequently drug addicts. And they are similarly seeing, you know, people who are mentally distressed, people who are having wage stagnation, things like that. It's also happening in, you know, parts of Europe, but there are also parts of Europe where it's not happening in the same clip. You know, I think there are a lot of things that can be learned from that, but, you know, America being Americans, you know, it's very difficult to teach us, you know, to follow another nation's path to some level of success. So again, you know, I'm not saying that it's going to be fruitless. And, you know, even in the same breath, I want to acknowledge those other countries, you know, that I'm referring to, you know, and to name names, I'll put names on it. Germany, for example, doesn't necessarily have the drug overdose issue that we have. Germany has its own issues. And historically, of course, we know they've had other issues that they for sure had to clear up. And that was a literal 2 wars. But, you know, they have done some other socially progressive things. Japan, you know, similarly has, you know, its own issues, but they are not necessarily these issues. I think that, you know, there's a lot of learning that could be done on the global scale where they similarly are learning from us in, you know, the cultural sense on, you know, the quote unquote freedoms that we have. And I'm not saying we need to give up any of these freedoms to find solutions to this problem, but we got to act. We got to do something. It's only going to get worse. And, you know, I was mentioning how this crisis, you know, really started off. Well, first off, I'll say it started to be tracked a lot better in the late 90s. First off, a lot of that and the increases that we see are increases in surveillance. You know, we got better at tracking and understanding, you know, what it was we were looking at, what we were looking for, defining it more than anything. So, you know, not surprised to see rates increase. But on top of that, the people and what those people looked like that were succumbing to drug overdoses became much more alarming for the media than what it used to be. And that very much fueled people putting resources into solving this problem. People's CEOs and, you know, executives, children were succumbing to these health outcomes and they were not liking it. And, you know, they were recognizing, oh, it's not just me and my kid, it's everybody or half my kid's school that's, you know, running into this problem and different things like that. So, you know, a lot of things in America do end up just coming back to race, but a lot of this stuff does disproportionately affect minorities, not just Black people as well. You know, obviously we talk a lot about Black people on this podcast, but Native American populations absolutely are killed, literally killed by this crisis at a incredible clip out in the Midwest and, you know, the South Dakota, North Dakota areas, different shit like that. There is not a ton of research on it just because that population is small and because nationally race ethnicity data is not the greatest. Many different institutions will tell you that just because it's just not captured the same everywhere. We're working on standardizing that in a lot of different ways. But, you know, the fact that we weren't measuring it at all for, you know, the 50 plus years that we've been doing this. And by this, I mean, you know, any kind of health statistics and tracking and measuring or doing it well. And, you know, we only just have started to kind of try to standardize and in 2020, because I think we changed it in 2022. So I'll say 2020 to be safe. Every state was measuring race ethnicity however they chose to, however they wanted to. They didn't all have the same ethnicities listed. They didn't have all the same races listed. Some of them, you know, included Creole as an ethnicity or just different things. You know, obviously places like Hawaii that are very, you know, separated from the United States are going to have their own demographics that they need to, you know, understand and measure and capture. But that's unhelpful if we're trying to assess, at the very least, the contiguous United States, if California is measuring their shit different from Georgia. And that's just an example. I can't remember if that one is, you know, exactly what it was. And again, we're trying always to improve. That's the best we can do.
Indeed.
Yeah, I mean, shit's crazy out here.
Well, I think, you know, that's trying to improve is a nice segue to kind of wrap up the podcast. You know, so I have a question, which is, and I'll have my own response as well, but like, you know, is this something you sort of foresee for yourself as like, we have gone about our careers in a way where we're trying to like kind of solve, you know, we're not going to be able to fix things, but, you know, we're working on some really challenging problems. I also think that we both maybe kind of stumbled onto onto fentanyl, you know, that one time in Costa Rica, you know, when we stumbled on. No.
You mean when we were like right on the border of Nicaragua?
Hey, well, you know,
that was crazy.
Yeah. But
you were gone for like 6 hours. You know, that boat just kind of randomly dropped you off. That was crazy.
We want to talk about, you know, you were talking about immigrants running across the border. We're trying to. That was me. Yeah, that was me. No, I'm playing. Anyway, but like I didn't go about my doctoral journey wanting to treat or study substance use. I think it does become a part of your training process because it's so prevalent across mental health, you know, challenges in general. But do you sort of foresee that you'll continue this this work?
Well, so I mean, I think it's fascinating. I think it's very interesting. I work with a different team now. I would love to return to that team that was doing a lot of drug overdose surveillance. Different things have and are changing in how, at least from the CDC side, we're researching it. When I started in 2019, the team was brand new. Like it used to be like 3 or 4 people nationally that were measuring all this stuff. And then we built a team out to like 12. And then, you know, our scientists were so good that we pretty much all just got poached by other teams to kind of elevate our careers, which, you know, is somewhat to be expected. But, you know, the resources have to be put into that research to bring, you know, talent back to it. I would love to come back and, you know, work on that, whether it's with CDC or otherwise. I think it's, you know, very much fascinating research. I think it's avant-garde. You know, I Google drug shit on my work computer all day when I was working.
Not a bad deal.
And like you said, yeah, I mean, I found, you know, I applied for that fellowship, you know, knowing what it was or whatever, but like I got the position and then learned everything about, you know, drug overdose surveillance. I didn't know these things beforehand. I had read some stuff here and there, you know, just to be informed, but like, you know, there's always so much more to learn. You know, obviously on our first postdoc podcast, we discussed like, you know, once you get the doctorate, you really kind of understand, oh yeah, I don't know anything. And, you know, that's very much how I felt. So, yeah, I'd love to return to it. I think it's fascinating, but we'll see.
Yeah, by the way, I think I probably have mentioned this before on the podcast, but there's something called the Dunning-Kruger effect, which is when people who have less knowledge about something feel more confident in how much knowledge they have. But I don't know what the opposite of it is. I'm looking it up online. It's saying imposter syndrome. But basically what you're saying is the opposite of the Dunning-Kruger effect, where the more knowledge you have, the less like confident you feel about your ability to understand the knowledge base, Yeah.
Yeah. And I mean, obviously like the Dunning-Kruger effect is about something very specific. And then like what I'm describing is, very broad. Like, I don't know anything about everything, but for specific things, yeah, I know I am the subject matter expert. I can, tell you what it is and And even within that, there are things that I just don't know and won't necessarily be able to describe if you were to ask me, certain stuff without me having, literally just read it. So,
right.
I mean, yeah, some of that is imposter syndrome. And for sure, I still, to this day, experience some level of imposter syndrome. And I've led some of these projects and things and shit like that I've been on. But it's, there's always something new to learn.
Mm-hmm.
I think that's where the imposter syndrome may come from. And I mean, I enjoy learning. I like to, all right, well, what didn't I know? What's new here? What can I pick up and add to my bag of tricks? So.
Yeah, for sure. Speaking of bag of tricks, I'm gonna go ahead and plug our new consultancy. No, I'm kidding. Your consultancy, statsrmybusiness, because that's the name of the game for getting a doctorate. I this was my mindset from when I started, which is why I did my dissertation doing machine learning. Is I'm trying to get transferable skills. So you're talking about a tool bag or a toolkit. Go ahead and hit up Herschel if you need some statistics consulting. And yeah,
please, yeah, we have some very happy clients. I'll tell you about it off mic a little bit more today, but yeah, I've got referrals if you care to hear. But we can of course set up a free consult, figure out what your problem is, and make moves from there. Yeah, I think that about wraps us up.
Well, one more thing. So I'll just say real quick. I don't necessarily foresee myself working in substance use like explicitly, but I consider myself a generalist in the world of psychology, which is probably more unusual than it sounds, because I think a lot of people want to develop very specific skill sets or work with a very specific population, which is a really good way to move up. But, I think there's so much more of a holistic way you can understand mental health, I guess, which is why I've been driven to have a more generalist identity. But so I don't foresee myself like working specifically with the substance use population. But if opportunities present themselves that are great, I'm definitely happy to dive in. What I will say is, I'm a little bit hopeful for psychedelics. I am a believer in psychedelic treatments, psychedelic therapies. I haven't really talked too much about it on the podcast, so I might have to do like a psychedelics podcast at some point. But a couple weeks ago, the FDA rejected MDMA therapy for the new drug application from Lykos Therapeutics for MDMA therapy. That was for PTSD. I have a lot to say about it. I won't get into too much detail. I think a lot of people were upset and sad, but I tend to maybe think of it as a blessing in disguise, because I think that psychedelic experiences are maybe not very amenable to the medical model that we have in our country, especially one that's so corrupt, as we were talking about earlier with hospitals closing and whatnot. But there is a very powerful, thriving research enterprise for psychedelic therapies. And one of the angles that are hopeful, that people are hopeful for in terms of treatment, is substance use problems, especially people who have very severe long-term addictions. I mean, these things are so hard to beat. And the idea is that psychedelics will give people a powerful psychological, I guess you could also say neurochemical experience that will give them an opening to escape the addiction, or at least just to get onto the off ramp and then, with continued treatments and holistic care and psychosocial and socioeconomic interventions, people can recover fully, hopefully. Again, I don't have a very specific or obvious path that I foresee, but I believe that if psychedelics can get some traction for treating addictions, I'd be very happy to be involved as a therapist or researcher. So, we'll see. The 2020s could be a real inflection point for the crisis, because you're talking about a fourth wave. I mean, come on, how many waves can we have? Eventually, it's just going to destroy our nation. We can't have no fifth, sixth, seventh waves.
I mean, yeah. I mean, so in terms of wave, it's one of those things where like it's a big increase. Like it's, the ocean got waves all the time. And then, it's the tide is essentially endemic, if you will. The fluctuations are what are really, really, really problematic. I was going to actually show you this because it's a graph. I was going to show you this after, but basically like what we graphed during my dissertation was like, oh, at the beginning of 2020, when we had the pandemic and shit like that, where social isolation and all these things were happening, there was a huge, huge influx. And then kind of because of that, again, kind of describing a wave there, and, the borders are opening back up. Drug supplies are, becoming more normal, I guess, to where things are not adulterated is what I'm describing there. Like when the borders shut down and people had to kind of scrounge and, add whatever the fuck to whatever drugs they were selling because they still needed to move whatever weight, and people were still clamoring for whatever, addicted substances they were looking for. There were essentially more deaths, different things like that, right? But yeah, we saw after it, maybe like 2022 or so, and I have not researched beyond 2022, so, there's new data that's always going to be continuing to come out. I think the 2023 data probably just became available. If not, it might still be proprietary. But, in the same sense of a wave, it kind of starts to come back down a bit, which is just interesting to see. We don't know we don't know whether it was like, oh, well, we actually made some policies that are affecting this, or, other societal things that just started to come back to normal, were, more so affected drug overdoses than, what we did. The economy shifted and changed within that, 2000 to 2002 period where, so many people were on unemployment and out of work, and then, started to get jobs again and have semblance of structure and shit like that. Like there are things that, it just becomes very difficult to measure. We measure the things that we can measure. So I'm sure even that article that published paper that you mentioned earlier probably describes like, oh yeah, there are so many outliers or confounders and different things like that. And so many things you can't even calculate, just immeasurables that we have to assign to randomness, in your model. And it ain't random. I mean, a lot of it is random. There is random, new shit happen every day. You don't know what the weather is going to be, whatever. But like a lot of it can be modeled. You can model the weather against drug overdoses, and you will see a pattern where there are increased overdose deaths and non-fatal overdoses in warmer months, summer times. Not sure if that's just because people are being more social and outside and doing shit, or if it's, they're in the sun and, passing out and requiring, direct medical care versus, being the wintertime and people are, more isolated a lot of the times. These may be social interactions where people are taking drugs rather than doing it by themselves. Some of these, particular drugs and these drug profiles are things that people are more commonly taking by themselves, but many of them are not. So, there's a lot of stuff that goes into this. And again, this is on a national scale. I'm not, at least as a statistician and epidemiologist, I'm not talking about on the individual scale. Oh, because, somebody, you have an anecdote, one person who only does drugs in the wintertime. Fuck out of here. I don't want to hear that. That's one person. That's your truth. That's fine. But that's not, what we're seeing in the data. And we can only go by, like I said, what we've measured, what we understand, and, I've said this before on the podcast, but like, all right, you have new and different findings. Well, tell somebody, go talk about it so it can be reported and can be included in the next analysis, please. Otherwise, we won't know. And you just saying it into a podcast. And that's all I got.
Well, I think that's a good place to end, Doc Talk Part 2. I guess, this potentially could be a series, but, we don't have anything in mind for the near future. But we will be having podcasts. Hashtag R2BTH is the name of the podcast. Subscribe on Spotify.
Follow us on Twitter. Shoot us an email at RTBTH. No, is it Real Talk?
realtalkbth@gmail.com. But hashtag RTBTH on pretty much just Instagram. If you want to, check in with us. But yeah, good talk, Herschel. I learned a lot, and we started off as a sports podcast, but we became more learned, and now I think we're doing a lot more science talk, which I love, and we definitely got hella sports that we got coming your way as well. But yeah, I learned a lot, Herschel.
Yeah, man, me too.
Yeah, I hope
great stuff.
I hope others learn a lot as well. And links in the show description. Otherwise, #RTBTH.
Peace.
#RTBTH. Real talk beyond the headlines. We out. We out.
Okay, give me a second to breathe.